Welcome, and thank you for joining us at Siemens Healthineers. My name is Dr. Derek Lenz, and I will be your moderator today. I serve as Marketing Manager for Plasma Proteins at Siemens Healthineers. I would like to introduce our subject matter expert and the content of this webinar, titled Evaluating MGUS, Monoclonal Gammopathies of Undetermined Significance with Free Light Chain in Clinical Practice. Our speaker today, Dr. John Mitzios, graduated with a Ph.D. in chemistry from the University of Ioannina in Greece, followed by a postdoctoral fellowship at the University of California in San Diego, as well as a clinical chemistry fellowship at Washington University in St. Louis, Missouri. John has had many research interests over the years, but he has primarily focused throughout his education and training on coagulation, with an emphasis on platelet function and biology. Additional experiences for Dr. Mitzios include faculty at Weill Cornell University as an assistant professor of pathology and laboratory medicine, as well as an attending assistant clinical chemist at New York Presbyterian Hospital. He's served as assistant director of the Special Coagulation Laboratory at BioReference Laboratories, and he currently serves here at Siemens Healthineers as a clinical consultant on scientific and clinical affairs. He is well published, having co-authored 20 peer-reviewed journals and 3 book chapters. Please join me in welcoming Dr. John Mitzios to the presentation. Dr. Mitzios, the floor is all yours.
Thank you, Dr. Lenz, for that introduction. So today we're going to learn, here are our learning objectives for today's talk. So we're going to define multiple myeloma and monoclonal gammopathy of undetermined significance, or MGUS. We're going to describe the clinical criteria used to define multiple myeloma, as well as describe the use of free light chain in the evaluation of MGUS. We know in the bone marrow there are a number of cells that are produced. For example, white blood cells, such as plasma cells, B cells, T cells, and natural killer cells, all help in fighting off an infection. In addition, we have red blood cells, which their primary function is to carry oxygen to tissues. In addition, we have various hemostasis cells, like platelets, which help in the coagulation process. But interestingly, in the context of multiple myeloma, what we end up having happen is an overproduction of these plasma cells, in which essentially the process goes haywire, producing an abnormal amount of plasma cells. Plasma cells make antibodies, which help fight off infection by recognizing or attaching to bacteria and viruses. I always like to equate an antibody to that of a Post-it, in which it tags the virus or the bacteria and targets it for destruction. Now, these immunoglobulin molecules are made up of 2 identical light chains, together with 2 identical heavy chains. The type of heavy chain determines the immunoglobulin class, such as an IgA, an IgD, an IgE, an IgG, or an IgM. Now, each specific plasma cell only produces 1 specific antibody, resulting in 1 specific heavy chain and 1 specific light chain, as shown in the slide. However, there's a slight overproduction of light chains, which can be detected circulating in their free form, that is, not bound to the heavy chains in plasma. These are called light chains. Multiple myeloma leads to an overproduction of plasma cells, resulting in monoclonal gammopathy, that is, an overproduction of these immunoglobulins and their associated light chains. I like this slide because it gives a snapshot as to multiple myeloma. When you look at the green line on the slide here and the graph, we can see the rate of diagnosis of new cases of multiple myeloma. In and around 2003, we can kind of see a sharp increase to the new cases of multiple myeloma that arise. And I attribute this increase to the better technology that we have at picking up these patients. In addition, we see the death rate associated with multiple myeloma in the black triangles. And again, at around the same time period of around 2003, 2004, we see also a decrease in the death rate. And I attribute that to the better medicine that we have at treating these patients with multiple myeloma. Overall, the better laboratory diagnosis, as well as the better treatment options, result in a 77.5% survival, 5-year survival rate. Now, multiple myeloma presents with relatively vague symptoms. Typically can present as back pain, and unfortunately all of us today have been experiencing back pain by sitting in our chairs for extended periods of time. Also, patients can experience bone pain as well as fatigue. As a patient presents to the physician with these nonspecific symptoms, if the clinical presentation is consistent with that of a plasma cell dyscrasia, in this case a multiple myeloma type of picture, the physician is able to do additional tests. One, to measure organ damage. The traditional laboratory evaluations for measuring organ damage in the context of multiple myeloma are defined by the mnemonic CRAB, which indicates calcium elevations or hypercalcemia, renal dysfunction, anemia, as well as bone lesions. In addition, the M protein is quantified by various techniques. One, we can measure intact immunoglobulins, or we can measure free light chains. There's additional assays such as serum protein electrophoresis and serum immunofixation, as well as urine protein electrophoresis and urine immunofixation. And finally, we can measure the serum free light chain ratio, which is a topic of today's talk. In addition, there are a number of other biomarkers, which now form another mnemonic that's commonly being used, is the SLIM CRAB criteria, where the SLIM represents 60% or greater bone marrow plasma cells, plus a light chain ratio greater than or equal to 100, and lesions found by an MRI being greater than 1. And I'll talk about specifically that light chain ratio of greater than or equal to 100 in the coming presentation. When we look at the progression of, or the disease progression of multiple myeloma, it's really broken up into 3 distinct categories. One is monoclonal gammopathy of undetermined significance, or MGUS. Typically does not present with any end organ damage, is non-asymptomatic, and typically it's a pre-malignant stage of multiple myeloma. Unfortunately, 1% of patients progress per year to multiple myeloma after being diagnosed with MGUS. The intermediate category, as I like to call it, is smoldering myeloma. And in this particular case, again, there's no end organ damage. Patients are non-asymptomatic, and about 10% of those patients progress within 5 years to multiple myeloma. And finally, multiple myeloma. The presence, typically the patients present with some type of end organ failure. 2 of the 3 are required. Typically, again, the patients are symptomatic, and they have a mean survival of about 5 years. And again, I alluded to about the 77.5% mean survival rate at 5 years. But what is a common thread for these particular patients? It's really our ability to monitor disease progression in these different disease states. Patients going from MGUS to smoldering myeloma to finally multiple myeloma. But what's important about these monoclonal gammopathies is how to properly assess these patients. This paper looked at different screening algorithms associated with monoclonal gammopathies. And I like this paper, even though it was published in 2009. What it does, it really highlights the importance of having adequate and appropriate screening processes in place in your laboratory. Here we have different states, looking at multiple myeloma, macroglobulinemia, smoldering myeloma, MGUS, and primary amyloidosis. What we see is if we take multiple myeloma as an example, out of the 467 patients that were analyzed, when using appropriate screening algorithms, for example, using serum protein electrophoresis, immunofixation, and free light chains, 100% of the patients were able to be adequately diagnosed. On the other hand, for example, looking at MGUS, about 524 patients were analyzed. And when you, again, apply appropriate screening algorithms, you can get more than 90% of those patients adequately tested and diagnosed when looking at using appropriate screening protocols. But before we start talking about specifically free light chains, let's kind of re-baseline everybody. We know that serum protein electrophoresis, also known as MSPEP, is an easy, inexpensive method of separating proteins based on their charge, size, and shape. The two major types of proteins present in the serum are albumin and globulin proteins. Now, albumin is the major protein component of serum and represents the largest peak that lies closest to the positive electrode. Globulins make up a much smaller fraction of the total serum protein, but represent the primary focus of interpretation of serum protein electrophoresis. 5 globulin categories are represented: alpha-1, alpha-2, beta-1, beta-2, and gamma, with the gamma fraction being the closest to the negative electrode. And again, this is what indicates the diagnosis or the characterization of the M spike. Now, when we look at the slide, when we look at the electrophoretic mobility, what we notice is that we have a normal distribution of the different fractions. We can see we have a normal albumin peak, and of course, the other 4 fractions are within normal ranges. I also want to point out that it's also important to make sure that the specimen quality for serum protein electrophoresis is appropriate and that an adequate serum specimen is being used. As a kind of, again, refresher, serum is devoid of any of the coagulation proteins, whereas plasma maintains the coagulation proteins. As a former lab director, what I've noticed in the past is I have seen what's called beta-gamma bridging. Sometimes you can get a bridge between the beta and the gamma, which may indicate the presence of fibrinogen or inadequately coagulated specimen. However, when we do get a proper specimen and we do run the serum protein electrophoresis, what we do see is that if we see an M spike present, much like we see in the slide just now, this denotes, 1, that there is an M spike. 2, we can quantitate it by doing densitometry. But the third thing that we need to do is we need to categorize that. In order for us to properly categorize the M spike, we need to do immunofixation techniques. This is just an example of different types of immunoglobulin characterizations that we see. For example, you can see that the one patient may have an IgG kappa, which is noted in the very middle panel. You can see the nice bands that are associated with the gamma spike, M spike, plus the IgG kappa that's seen. Now, this is important to categorize these monoclonal gammopathies in order to properly treat these patients. Now, there are 2 types of free light chains. There's free light chain kappa and free light chain lambda. Now, kappa free light chains circulate as monomers of 25 kilodaltons, while lambda free light chains are usually present in dimers of 59 kilodaltons. As small proteins, free light chains are freely filtered by the kidney. The smaller free light chain kappa complexes slightly more efficiently than the larger free light chain lambda molecules, resulting in a half-life time of about 2 to 3 hours for free light chain kappa and about 4 to 6 hours for free light chain lambda. The short half-life time is important for monitoring the therapy response in monoclonal gammopathies, as the complete immunoglobulin complex shows a much longer half-life. For example, the shortest is IgG at around 3 weeks. Now, like other small proteins, like cystatin C, for example, or alpha-1 microglobulin, free light chains are reabsorbed from urine by renal tubules. When the reabsorption capacity is maxed out, free light chains are excreted in the urine, resulting in overflow proteinuria, also known as Bence-Jones proteinuria. And this is where urine immunofixation may play a significant role. Now, for healthy individuals, concentrations of free light chains are relatively low, and there are equal concentrations of both types of light cells. It is normal for the concentration of both types to increase when immune system is, for example, stimulated. If a patient has a chronic inflammation or has a chronic infection or has an autoimmune disease, free light chain ratios may be elevated. On the contrary, there is a decrease observed when patients experience some type of renal dysfunction. I also want to point out that the reference ranges for these normal kappa to lambda ratios may change depending on the assays being used. Unequal concentrations of free light chain kappa and lambda, either through kappa overproduction or lambda overproduction, result in abnormally high or low free kappa to lambda ratios. Now, this is an indication of a plasma cell disorder such as a monoclonal gammopathy. But I also want to point out the importance of what I refer to as the involved free light chains. For example, if we have an elevated kappa to lambda ratio, the involved free light chain in this case would be kappa, whereas the uninvolved would be lambda. On the other hand, if we have a low free kappa to lambda ratio, the involved free light chain is the lambda, where the uninvolved is kappa. And I want to point out this is important, especially when interpreting these results for kappa and lambda ratios. I really like this slide because it really highlights the importance of why free light chain testing is more sensitive in detecting myeloma. So just imagine that we have a fresh basket of oranges. In a situation in which a patient is presenting an early stage myeloma, which is MGUS, for example, if I measure intact immunoglobulins in the context of these basket of fresh oranges, can I really tell whether or not there is an excess amount of oranges when I'm looking at the basket as a whole? The answer to that question is no, because you really can't tell whether 1 or 2 or even 3 oranges have been placed in that basket of fresh oranges. Where the free light chain, this is where it distinguishes itself, is that, for example, instead of measuring the whole orange, you're measuring a piece or a slice of that orange. For example, in a healthy patient, we have 2 slices, as an example. As the patient begins to progress and is in this MGUS stage, instead of having 2 slices, now we have 4. There's an effective doubling of the number of slices. This allows you to have a better picture as to the patient's status. Now, in detecting free light chains, free lights for each patient is unique in its variable region, as denoted here in the slide. However, the constant region for this free light chain assay are identical from patient to patient. In addition, different vendors may use different methods to prepare the antibodies. For example, there's a polyclonal antisera that can be used, as well as monoclonal antibodies that can be used to help distinguish or pick up these free light chains. Now, this slide just looks at 3 of the vendors that have free light chain assays available. And these vendors, for example, one is Binding Site, which has been in the market for a number of years now, has the free light assay, and it's a polyclonal assay. Siemens has an N-latex free light chain assay, and it's monoclonal. And there's a third company by the name of Diagnostic, which has another human free light chain assay available, and again, it's a polyclonal assay. So remember, these are 2 tests looking at free lambda kappa and free lambda, and we're looking at 3 numbers: kappa, the lambda, and the kappa to lambda ratio. I also, just a point of clarification on this slide, I've denoted where the antibodies bind but this is just for illustrative purposes, is it does denote that the N-latex assay binds to the constant region, whereas the free light binds to the variable region. Again, this is just strictly for illustrative purposes. Now, the N-latex assay is FDA approved, and it's approved for the aid in the diagnosis of multiple myeloma, AL amyloidosis, as well as MDS. Again, it's a multi-monoclonal antibody that's used to detect free lambda and free kappa. It's comparable to the free light assay. In addition, it has overall good lot-to-lot consistency, and it avoids false positives in patients with renal dysfunction. However, it's really important that you interpret the data in a stepwise fashion. Number one, we should always interpret any type of free light chain data together with the complete clinical picture. That is, we take all the data that we have, the laboratory data, which can include your calcium, your creatinine, your hemoglobin, for example, your serum protein electrophoresis, and your UPEPs. All the laboratory data, plus the imaging results, plus the clinical presentation of the patient to interpret the free light chain data appropriately. When looking at the kappa and lambda, if you have a high kappa to lambda ratio, that strongly indicates that the involved light chain, in this case, is the kappa. If you have a low kappa to lambda ratio, this indicates that the involved free light chain, in this case, is lambda. You also want to verify the results by looking at the involved elevation. If there's no elevation, then there's no evidence for a monoclonal light chain by this method. You also want to look at the uninvolved. If low, then that may explain that the abnormal ratio is without evidence of a monoclonal light chain. So it's really important to look at this in a stepwise fashion. So when we look at the N-latex assay, it recently has been given FDA a clearance for an MGUS claim. And this is just a snippet from the intended use of for the instructions for use for the N-latex assay. Now, it's really as an aid in the evaluation of monoclonal gammopathy of undetermined significance. It can be used on the BN system as well as on the Teleca CH analyzers. But remember, the results of any type of free light chain measurement should always be interpreted in conjunction with other laboratory as well as other clinical findings. Now, in this study conducted by Granite colleagues, using the Siemens Healthineers N-latex assay, they showed, for example, in panel A, that there was no significant difference in the time to progression in the group that had measurable disease by SPEP and involved free light chains. In panel B, in patients who had measurable disease by SPEP only, the progression was observed significantly earlier with SPEP compared to that of IFLC. However, IFLC detected progression significantly earlier, that is at the 19.6 months time frame, compared to the urine protein electrophoresis, which detected at 63.7 months, in the group with measurable disease by UPEP and IFLC alone. Now, this study really just highlights the importance of monitoring or measuring the involved free light chain assays when compared to SPEPs, especially in patients with progression more than 18 months after best response to therapy. Now, the upper curve illustrates the risk of progression of monoclonal gammopathy of undetermined significance in patients with an abnormal serum kappa to lambda ratio. Again, in this particular case, we're using 0.26 to 1.65. Again, depending on which assay one uses, those ratios may in fact change. And what this basically shows is that those that had an abnormal free light chain ratio had progressed to multiple myeloma. And I really like this particular slide, or figure, excuse me, that shows that depending on which side of the ratio you fall on, there is an increased relative risk to progression to multiple myeloma. So the more abnormal your ratio is, the higher risk of progression. And again, using that 0.26 to 1.65 ratio here. Monoclonal gammopathy of undetermined significance is a pre-malignant clonal plasma cell disorder, as we've already described, with a 1% relative risk of progression to multiple myeloma. Now, certain risk factors determine the likelihood of progression from MGUS and smoldering myeloma to multiple myeloma. For example, an M spike of greater than 1.5 grams per deciliter, being over the age of 65, and having an involved free light chain of more than 100 milligrams per liter. Now, these risk factors help physicians determine who is likely to progress to multiple myeloma, diagnose them early, and find out which patients need to be treated early. Now, this study that was conducted by the International Myeloma Working Group carried out using the N-latex free light chain assay and found that patients with none of these risk factors have a 2% 5-year cumulative probability of progression to multiple myeloma, whereas patients with 2 or 3 of these risk factors have a 31% 5-year cumulative probability of progression to multiple myeloma. This was essentially verified in another study that was conducted again by Gran, which showed again in those patients that progressed to multiple myeloma, as indicated in the teal color, those patients had a higher, had more of these risk factors compared to those patients that did not progress with MGUS that did not progress to multiple myeloma. Again, seeing the M protein greater than 1.5 and the involved free light chain greater than 100 milligrams per liter. An increased involved free light chain greater than 100 milligrams per liter showed here, where we can see that again, the risk factors here. Any of these risk factors greater than 100, an M spike greater than 1.5, or 65 years of age or older, these patients, the more risk factors one patient has, the more relative risk of progression to multiple myeloma there is. This is nicely illustrated by this figure here, which shows the number of risk factors, and here, if you have 2 or more risk factors in that kind of grayed out line, the risk of progression is significantly more elevated. So this study did a nice comparison by just looking at the M protein versus the involved free light chain. I just want everyone to focus on the baseline values first before we go to the any time. So baseline means at any point at the baseline value, if the patient had M protein that was greater than 0.5 grams per deciliter increase, the risk of progression is highlighted in the black line. And the shaded region essentially means the 95% confidence interval. But you can see that around the 50-month time frame, after follow-up, you can see that the risk of progression is around 1 to 3%. However, if the patient had an increase greater than 100 milligrams per deciliter at baseline, if the involved free light chain was elevated, greater than that 100 threshold, you see that the relative risk of progression increased dramatically to about 6 to 7%, even over that 50-month time period, indicating that involved free light chain may be a better marker at picking up patients that progress to multiple myeloma. The any time is at any time during the course of the follow-up, if the M protein was greater than 0.5 grams per deciliter increase, you can see that the risk for progression actually decreased as the follow-up was longer. So, for example, at the 20 versus the 50-month time frame, you can see there's a significant decrease. However, with the involved free light chains, you can see that there's an increase in the progression or risk of progression to multiple myeloma, as shown again in the figure or panel D. So this study that was done by Landgren showed that in panel C, for example, those patients that progressed to multiple myeloma, or that did not progress, did not exceed the 100 milligrams per liter. You can nicely see that the trend line, which is indicated in orange, shows that these patients did not exceed that 100 milligram per liter threshold. On the other hand, those patients with MGUS that progressed to multiple myeloma, you can see that there's a much wider variation in their involved free light chain concentration, and the trend line, again, the orange line, shows a significant increase, indicating again that the involved free light chain may be giving useful information as to the progression of disease or progression to multiple myeloma in these patients with MGUS. A revised diagnostic criteria that was proposed aimed to accurately identify high-risk and ultra-high-risk smoldering myeloma patients. Now, the revised definition, known as the Rule 100, and I alluded to this in the beginning slides, included clonal bone marrow plasma cells of equal to or more than 10%, and one or more of the following myeloma-defining events. That is, clonal bone marrow plasma cell percentage of equal to or more than 60%, and involved to uninvolved serum light chain ratio equal to or more than 100, and more than one focal lesion on MRI studies. This has helped to define or determine which smoldering myeloma patients are most at risk of progression to multiple myeloma and who will therefore need further treatment. In a 2019 study done by Henrot and colleagues, they found that both the free light and the N-latex assays can be used to accurately identify high-risk and ultra-high-risk smoldering myeloma patients when using the Rule 100 criteria. However, Henrot also concluded that the N-latex assay could also be used for smoldering myeloma patient monitoring like the free light, and that the N-latex serum free light chain ratio of greater than or 70 appeared to provide similar performance to a serum free light chain ratio of greater than or equal to 100 with a slightly better positive predictive value. So smoldering myeloma is a plasma cell disorder, as already described, as that intermediate category of multiple myeloma or the disease progression with a 10% yearly risk of progression to multiple myeloma. So in 2020, the International Myeloma Working Group, or IMWG, took it upon themselves to develop a risk stratification model to identify these smoldering myeloma patients, which were at high risk of progressing to multiple myeloma or some other plasma cell disorder. And what they did is they looked at 4 independent factors, and they developed this 2-20-20 risk stratification model. It looked at 1, serum protein spikes or M spikes greater than 2 grams per deciliter, involved to uninvolved free light chain ratio of greater than 20, and marrow involvement of greater than 20%. And the 4th criteria was looking at cytogenetic abnormalities. And they assessed how these patients progressed to multiple myeloma. And 1, it helped identify these high-risk patients better and is widely applicable. Now, this graph shows that using the 20-20-20 model with 3 risk factors allows to determine within the first 2 years from diagnosis the likelihood of patients progressing from smoldering myeloma to that of multiple myeloma. We see that smoldering myeloma patients with no risk factors have a 6% chance of progressing to multiple myeloma, while those with 1 risk factor have an 18% chance, and those with 2 or 3 risk factors have a 44% chance. This second graph shows that including cytogenetic abnormalities in the risk stratification model means a group of patients who are at even higher risk of disease progression can be identified earlier. We see that those patients with 3 or more risk factors including those of cytogenetic abnormalities, are categorized as high risk and have a 63% chance of progressing to multiple myeloma 2 years after diagnosis. Now, that's all great about the laboratory diagnostics, but what do we really measure in all these models that are currently being used? But how do we really take that into practical use? Well, for example, the IMWG guidelines looked at and says, well, if your patient is of low risk, that is, they have a normal free light chain ratio, their M spike is less than 1.5, and it has an isotype of an IgG, for example, it requires infrequent monitoring. Well, if your patient then becomes high or intermediate risk, where your free light chain ratio becomes abnormal, your M spike is greater than 1.5, then perhaps a more recent monitoring system is recommended. Grant study looked at it slightly differently, and it categorized again into the patients into three groups: low, intermediate, and high. Where instead of having broad or long times between monitoring, suggesting that the patient should be monitored, let's say, every 6 months for MGUS. If the patients are at a higher risk, perhaps a 3-month interval is recommended. So there's a lot of work and a lot of discussion going on which is the appropriate risk stratification model for patients with MGUS to decide what and to see how they progress and if these patients progress to multiple myeloma. Because as I said earlier, the importance of free light chain ratio is perhaps the ability to diagnose these patients earlier and being able to treat them more effectively. So in conclusion, we know that multiple myeloma is a cancer of the plasma cells. Again, reiterating that basically the plasma cells go haywire, producing all sorts of immunoglobulins, primarily of one specific isotype, along associated with a specific free light chain. Free light chain assays are important in monitoring MGUS progression, as I hope I've been able to convince you that looking at these free light chains, either as the involved or the free light chain ratio, there are good markers at monitoring the progression of MGUS to perhaps multiple myeloma. But there is one problem. There's a lack of standardization, and it's important to know which assay is being used. For example, if one hospital system is changing from one to the other, it's really important and really critical that proper communication is done, clinicians are informed of the change, and to really think about rebaselining your patients. Because really, free light chains are in fact tumor markers, and it's good to rebase them because reference ranges will change, ratios may change, so it's good to reestablish that baseline when a new method is implemented in your laboratory. And finally, it's always important to interpret the data in correlation with the clinical picture. The laboratory data provides the necessary information for the patient and the clinician to make the diagnosis, but it has to be interpreted within the overall clinical context. We as laboratorians are able to provide the necessary tools and the information to the clinician, and the clinician takes those tools and put that piece of the puzzle together to provide and to have an accurate diagnosis. And with that, I'd like to thank everyone for your attention, and I will turn it back to Dr. Lenz for any questions. Thank you. Dr. Lenz, the floor is yours.
Thank you, Dr. Mitzios, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Simply just click on the Ask a Question box located on the far left of your screen. We'll answer as many of your questions as we have time for. Before we get started with that, though, let's ask a couple of poll questions of you, if you'd be so kind. First poll question is yes or no. Are you currently involved in research or clinical diagnosis of MGUS, multiple myeloma, or AL amyloidosis? And the second question, I think that's it for the poll questions. My apologies. Let's dive into the seed questions, as there are quite a few. Dr. Mitzios, first question for you, please. I work in the field of nephrology, and I'd be more interested in your comments on elevated free light chain in patients with chronic kidney disease.
Can you guys hear me?
Yes, very well, thank you.
So in the context of chronic kidney disease and elevated free light chains, we have to reinterpret these results within the appropriate clinical context, right? And of course, it also has to do with the different types of assays that are currently being used. So, for example, if a patient with multiple myeloma and chronic kidney disease is being analyzed, let's say, or is being having their free light chains tested, there could be instances in which you can perhaps have a false elevation in your free kappa, for example, if you're using a polyclonal specific antibody against the free light chains. This could perhaps lead to a misinterpretation of advancing or progression of disease. So again, interpreting the results with an appropriate clinical context is of course appropriate. And of course, you also have to look at what happens with the free lambda chains as well. Are they also increasing or are they stable? So again, there's a lot to digest, especially when looking at free light chain assays in the context of chronic kidney disease.
Excellent. Thank you for that answer. And to the person that posed that question, let us know if further comment would be helpful. Moving along, Dr. Mitzios, to the next question. Are there other conditions in which free light chain measurements might be of benefit?
So free light chains, again, it can be benefit in in a variety of clinical conditions, especially if patients have systemic inflammatory disease. So where free light chains can be elevated in certain clinical contexts. So we also have to, again, look at the clinical situation and what the other clinical data as well as the laboratory data present. So for example, if a patient presents and they have, let's say, for example, some type of a plasma cell proliferative disorder, they may be used for either monitoring the disease progression and or treatment. In addition, they could be used for other disease states, for example, like AL amyloidosis or light chain deposition disease. So there's a number of clinical conditions in which free light chains can also be used outside of the context of MGUS or multiple myeloma.
Excellent. Thank you for that answer. Next question from the audience, a little bit more of a general question. What does a typical lab protocol look like for validation?
Again, that really often depends on the laboratory that's about to validate, let's say, the free light chain assay. And again, validation protocols are pretty much standard or similar across the board, but again, there may be some differences. But typically, you want to do your, precision studies, your correlation studies, doing any type of reference range studies and/or verification or validation, and that's just to name a few. But again, in most cases, the validation protocol will be provided by a vendor and can sometimes be modified or tweaked by the institution. But I also want to stress the importance of the following, especially when looking at free light chain assays, or if you're changing from one free light chain assay to another free light chain assay. Oftentimes, the method validation may not be a perfect match, let's say. So what's also important when looking at these validations, for example, for free light chain assays, it's really also important to look at clinical correlation studies or clinical concordance tables, let's put it this way. So the importance thing is making sure that you are within reason or making similar diagnostic claims by transitioning from one to the other assay. In addition, it's also important once you've gone live with the newer assay to always re-baseline patients when needed. So you can really just think of your free light chains as being tumor markers. So any change in tumor markers methodology also results in re-baselining. And this is kind of the similar approach that you will want to approach patients who have free light chain assays. Or, sorry, there was or when you're changing free light chain assays from one vendor to another.
Excellent. Thank you for that answer, Dr. Mitzios. It seems to be a popular subject. There are two other questions that are similar to that. So to the individuals that asked those questions, let us know if that answer was helpful or if you would like additional follow-up comment. I actually have one for you before we get to our last question. I often have discussions with customers in the field about the merits of measuring just kappa and just lambda versus those also looking at the ratio. And I'd just be interested if you had any thoughts or comments on that discussion.
Well, I think it's important to look at all three of these parameters. I think when you just focus on one of the three, or just focusing on, say, free cap, or just focusing on free lambda, it really doesn't answer your overall clinical question, because there's also what's referred to as the involved versus the uninvolved light chain. So if you're looking or monitoring disease progression or monitoring a patient who has MGUS, it's important to look at them in the three of them as a whole, and then tie it into the clinical context. So individually, I think they do provide some information, but I think as a whole, they provide the most useful information. I'll just give a quick example. If you're monitoring a patient and you're looking at both a free kappa, free lambda, as well as a kappa to lambda ratio, if you notice, for example, that the free kappa seems to be increasing more prevalent, more consistently than that of the free lambda, or based on previous results, that may be an indication that the patient may be progressing to something much more severe, in this case, a multiple myeloma, if the patient was diagnosed with MGUS. So I think it's important to interpret the results and look at the results as a whole, and using all three of those parameters together.
Thank you for that answer. And I saved this last question, which I found kind of interesting, a little bit of deviation from the normal question formats we might receive. It's a hypothetical question that an audience member is asking, and it goes as follows. A 30-year-old male with elevated free light chain kappa and lambda, but the ratio is normal. Additionally, the patient has normal renal function as measured by normal creatinine. So the question is, of that hypothetical, what could this patient have? What do the free light chain results tell me?
So it's an interesting question, because we kind of addressed the false elevation in patients who have kidney disease based on antibody design and so on and so forth. But in a situation in which there is both elevations in both your kappa and lambda light chains, in the absence of kidney disease, as indicated in this hypothetical example, this may indicate that, for example, chronic inflammation or a strong inflammatory response, or even some type of immune system disorder. But again, it's really important to interpret all the results that are obtained within the appropriate clinical context. So looking at the clinical signs that the patient's experiencing, looking perhaps at other laboratory parameters, even going one step further, for example, looking at a patient's serum protein electrophoresis or immunofixations, all of which can tell a story behind what the patient's currently experiencing before we make an official diagnosis. Because we want to point out that free light chains or free light chain measurements is a portion of your overall clinical picture. It's a snapshot in time of what the patient's experiencing. So we take all those pictures that we are able to take from the laboratory side of things, it puts a next little overall picture of what the patient is currently experiencing. So again, you can't just use, let's take, for example, the free light chains by themselves. We have to look at the entire clinical picture.
Excellent. Well, this is putting us to the end of our session today. But before we go, Dr. Mitzios, thank you again for your time and your expertise today. We would also like to thank LabRoots and our sponsors, Siemens Healthineers, for underwriting today's educational webcast. Before we do go, I'd like to thank you, the audience, for joining us today and for your interesting questions. Any questions that we did not get to today can be submitted during the on-demand period of this presentation, and we will be addressed by the speaker via the contact information you provided at the time of registration. So again, if we did not get to all of your questions today, we certainly will provide answers for you during the on-demand time. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We also encourage you to share that email with your colleagues who may have missed today's live event or who have interest in this subject matter. So until next time, thank you, everyone. Take care and have a nice day.